Hello, my name is Paul Friedman. I'm chair of the Department of Cardiovascular Medicine at Mayo Clinic in the Midwest, and I'm delighted to have my colleague with me, Dr. Jeffrey Geske, expert in cardiac imaging and hypertrophic cardiomyopathy in specific. Jeff, thanks for joining me.
Thanks for having me.
There's a lot going on in the world of hypertrophic cardiomyopathy, which had always been, if you have symptoms, in our case, surgery, occasionally alcohol ablation. But tell us about the drugs that are in the pipeline and that are available now.
Yeah, so there's been a lot of changes recently. After many years of kind of no therapeutic clinical trials in this disease, in 2022, there's a new drug FDA approved for treatment of obstructive hypertrophic cardiomyopathy. It's a new class of drug called myosin modulator, or myosin inhibitor. And the drug that's been approved, there's just one FDA approved right now, and it's called Mavacamten. And Mavacamten is really designed to treat symptoms caused by obstruction in HCM. And like you said, we for a long time have said, first of all, we'll start with lifestyle modifications, hydration. Then we would go into kind of the baseline therapies of beta blockade, non-dihydropyridine calcium channel blockade. And then when we get medically refractory patients who still have severe obstruction driving their symptoms, then we would turn to septal reduction therapy, with the gold standard being myectomy and an alternative being that of alcohol septal ablation. And when the 2020 guidelines came out, obviously before the approval of this new drug, that's really kind of been the lay of the land. But now there's been just a lot of changes and evolutions of how we look at obstruction and treatment of obstruction with this new drug around.
So let's talk a little bit then about how this fits into the diagnostic and therapeutic, really, armamentarium. So first of all, what stage, who are the patients who you would think about Mavacamten as opposed to surgery or alcohol ablation?
Yeah, so that's a great question. And I will say we're kind of figuring this out as we go. There are ongoing trials that are kind of exploring various uses of this. If we look at the phase 3 clinical trials, so this is going to be Explorer and Valor, which are the two main phase 3 trials of Mavacamten. And Explorer looked at largely NYHA class 2 patients with severe obstruction, and Valor was a more symptomatic population, NYHA class 3 patients who were considering septal reduction therapy. That was actually a requirement for going into the trial, was that they would be considering whether or not to go to myectomy or alcohol septal ablation at that point. And what those trials have really shown is that in these patients with severe obstruction driving their symptoms, that it's quite effective at reducing the LVOT gradient. And actually just this week, so June 2023, we saw that the FDA approved a new expansion of Mavacamten's prescription process that allows for knowing that Valor showed that Mavacamten reduces the need for septal reduction therapy. So patients who were on the drug within the study, after longer-term follow-up, were less likely to be eligible still for septal reduction therapy.
That's fantastic. Avoiding surgery seems attractive, but there's still the decision, because surgery is established, it's effective. So how do you decide? Because even though we're learning as we go, there's a patient in front of you in clinic. You've tried beta blockers or calcium channel blockers. They're hydrating themselves, and they have a gradient that you've measured on echocardiography or some other imaging study. How do you decide with the patient? What kind of conversation do you have, whether to use medication or surgery?
Yeah, I think that this is not one size fits all. And really shared decision-making comes into this. I think at this point, we can say that Mavacamten has an attractive safety profile, meaning that adverse events are low. We do know that it reduces ejection fraction, as one would expect for a negative inotrope, and that there is a small fraction of people where we see a robust reduction in ejection fraction. and varies a little bit depending on the trial that you look at, but somewhere on the order of around 5% of patients will develop an EF less than 50% during the course of treatment. Thankfully, that recovers with adjustment of therapy. But I think that there is not always patients that need to go to Mavacamten. Sometimes septal reduction remains the appropriate next step. And when I'm discussing this with a patient, I think when we have someone who's gone through the standard of care, lifestyle modifications, and what I would think of as baseline medical therapy, and now we're considering a more advanced therapy, then I'll want to know what their goals are. And if their goal is to avoid a procedure, even at the expense of taking another medication and much closer medical follow-up, well, then that seems like someone who's headed down the road of trying Mavacamten. On the other hand, if it's someone who says, listen, I'm so tired of seeing doctors, I want to take less medications and I want a mechanical fix to my obstruction, then that's someone that really would value this, the septal reduction therapy. And they're not mutually exclusive. Sometimes a patient may try Mavacamten and then realize that the drug-drug interactions are prohibitive for them, or that the follow-up is bothersome or onerous, or that that they didn't get the symptom relief that they wanted from that medication. Well, then septal reduction therapy remains an option after the drug is washed out.
So suppose you're not someone who has a large cohort of hypertrophic cardiomyopathy patients, and your patient is prescribed Mavacamten at a center of excellence for hypertrophic cardiomyopathy management. What do you need to know in terms of drug interactions, in terms of monitoring, potential side effects, how to advise the patient? What kind of guidance do you give patients for the follow-up on the medication, and physicians?
Yeah, it's a great question. And I think it's something that becomes increasingly relevant as we see this medication in practice. So for prescribers, there is a REMS program. So there's a mandatory program through the FDA that is needed in order to follow this drug because it's just been FDA approved. And so prescribers need to be enrolled in that REMS program in order to give this medication. And really, there's close follow-up that's required. So an echocardiogram is needed before initiating therapy to prove that ejection fraction is normal and that there's severe outflow tract obstruction. And then there's very close echocardiographic monitoring. So we said already that there's a baseline pre-therapy echo that's needed. But then an echo is needed at 4 weeks, 8 weeks, 12 weeks, and every 3 months thereafter, every 12 weeks thereafter, which means that there's 7 echocardiograms at least in the first year of therapy. That's a large amount of echocardiographic monitoring. And so I think patients and their local providers need to be aware of that need for monitoring. And then I think another key aspect, even beyond that echocardiographic monitoring, is that there are some significant drug-drug interactions with Mavacamten. And really this relates largely to CYP3A4 inducers and inhibitors, as well as CYP2C19 inducers and inhibitors. And while that's a mouthful, what it oftentimes translates to is that some fairly commonly used medications like omeprazole, Prilosec, or esomeprazole, Nexium, or a lot of commonly used antibiotics can have serious interactions with this medication. And so I've told patients that I place on this medication, if someone's going to place you on any sort of new medication or you're going to take anything new over the counter, I want you to reach out to me first just to get the okay to make sure it doesn't interact with your medication.
Yeah, that's really something that's important to be thoughtful about. I'm going to ask you to speculate for a second, because as we know in our own practice, the artificial intelligence ECG can detect hypertrophic cardiomyopathy, and we've seen that starts to normalize on therapy. And it also detects left ventricular dysfunction. And it's too early to know, but do you think potentially that could help in the follow-up of these patients? What are your thoughts in that regard?
Yeah, I think the recognition that echocardiographic monitoring is so necessary at the present, and how that evolves as we gather more and more safety data and we have longer term use will be interesting to see. But I do think that that's quite labor intensive. It's quite resource intensive. And so coming up with a way that we can monitor this in an easier fashion certainly is attractive. And I think that your inquiry with regards to AI applications is certainly one that is being actively explored. Yeah. And I don't know if I can spoil any punchlines or things, but I do think that this is something that we need to ensure we fully looked at, because it may really help with the monitoring of these new drugs.
Now, we've been speaking predominantly about Mavacamten, of course, but there are new drugs in the pipeline, not yet approved in the United States. Tell us a little bit about that and what the potential differences in promise of one versus the other will be.
Yeah, I think the big one that's coming down the pipeline is not Mavacamten, but called Aficamten. And Aficamten is presently in a phase 3 clinical trial called Sequoia. And so we don't have any data yet from Sequoia that's available, but this is looking at Aficamten for treatment of dynamic outflow tract obstruction in symptomatic HCM patients. So the initial studies are looking at a similar indication to what has been studied for Mavacamten. And there are, I think, two key differences in drugs. And one is that Aficamten has a shorter half-life. And the clinical take-home from that is that if dose adjustments are needed, the kind of seeing those dose adjustments takes less time. And so that may be an advantage for Aficamten. The other is that at present, there are no known drug-drug interactions. And so for someone who maybe has gastroesophageal reflux disease and is struggling to be off of their therapy that they needed for that indication, going with Aficamten may be an alternative to someone who is struggling to take Mavacamten because of those drug-drug interactions. And so I think that will be an interesting area to see how these play out if Aficamten is FDA approved in the future. I don't know that we'll have any head-to-head data on Aficamten versus Mavacamten for quite some time, or who knows if that will ever happen. But I do think that it's exciting to hear that there are alternatives and new drugs coming down the pipeline.
No, and it's very exciting.
In addition, it will be great to see as we expand the study of when to use these drugs. Should we be using them earlier because we've seen improvements in biomarkers like BNP? Should we be using it for non-obstructive disease? And that's an active trial that's ongoing for Mavacamten and one that's being started for Aficamten as well, because we've seen in some of the longer term data for the Mavacamten trials that diastolic dysfunction improves. And how does that translate then to a non-obstructive cohort? It'll be fascinating to see what else these drugs can do.
I think that's probably been one of the most exciting possibilities, that we may have a pharmacologic treatment for diastolic dysfunction that's completely novel compared to other treatments that have been considered for that in the past. What are the unanswered questions regarding these new therapies that you'd like? We've touched on a number of them already, but are there any others that you'd like to comment on? And we've also talked about the issue of, deciding on alcohol ablation and myectomy. But as you address unanswered questions, I'll also ask you to speculate whether you think that the mechanical interventions will wane over time, and whether we'll see pharmacologic replacing them, or do you think there'll be a place for both?
Yeah, so I think that as with many medical discoveries, answers drive more questions. And so I think we want to know more about long-term data. There's been through the Explorer trial, we now have some 84-week data that's come out, but really for septal reduction therapy and myectomy, we have decades of data.
Yeah.
So how do these drugs perform long-term? And what do we see as far as LV systolic dysfunction outcomes? Like for someone who's been on this drug for a year, does the risk of developing significant LV systolic dysfunction go down, or is it ever present? And how will we see this drug affect remodeling? Will we see that there is hypertrophy regression? Will we see that there are changes in left ventricular configuration beyond reduction of outflow tract obstruction? So I think there's a lot of different questions that are in the mix here. Scar burden, left atrial size, pulmonary hypertension, a lot of different things that will come about. And even things that sound at first straightforward, but sex differences in therapies. We know that women with hypertrophic cardiomyopathy present with more severe phenotype, that they have worse obstruction by the time they're referred, that they're more symptomatic, that they have more pulmonary hypertension, and that they have worse all-cause survival. And so do we see that they have the same response to this therapy as to others? So I think there are a lot of questions that need to be answered there. And
how about arrhythmias, Jeff?
Well, look at who I'm talking to, right? And I think that will be a wonderful area to explore more and to see how does this affect outcome data? Be it ambulatory monitoring of arrhythmias, be it appropriate ICD discharge, be it sudden death, and I think that really requires longer term data, because most patients with hypertrophic cardiomyopathy do fairly well as far as survival. We need long-term data to understand if there are mortality benefits.
Yeah.
Now, to your second question about sept reduction therapy, I think that there will always be a role for sept reduction therapy. And we know when there is concomitant structural disease, so primary mitral regurgitation, primary valve abnormalities, that this is an important technique, that it's an important operative intervention. And we also know that obstruction can happen at many levels. And while we've really studied Mavacamten for treatment of outflow tract obstruction, mid-ventricular obstruction is a real entity as well. And seeing how drugs do for mid-ventricular obstruction, or whether that's something that requires procedural intervention, remains important. And to me, seeing how new guidelines put together this new tool in the toolbox will be really important. I think that because the guidelines came out before FDA approval, and since we've seen this renaissance of therapy, we would expect that a new guideline update is forthcoming to help integrate this into our treatment protocol.
Dr. Jeffrey Geske, thank you for reviewing this fascinating topic. Really exciting times for patients with hypertrophic cardiomyopathy, and likely far beyond, as we learn how to use these medications and who may benefit and how to monitor them. Thank you for your time today.
Thanks a lot.